In the world of advanced hemodynamic support, we are often taught that if the tank is empty, we fill it, and if the pipes are loose, we tighten them with norepinephrine. But what happens when you've maxed out every adrenergic receptor and the map is still sliding? We are discussing methylene blue because it represents the ultimate plan B for the vasoplegic patient. When systemic inflammation, specifically post-cardiopulmonary bypass SIRS, creates a massive overproduction of nitric oxide, your standard pressors lose their grip. Methylene blue is the surgical strike that goes inside the cell to shut down the cGMP pathway and restore vascular tone from the bottom up. This isn't just a rescue drug, it's a pharmacological reset button. Today, we're covering how to use it safely, how to avoid the serotonin storm, and why it is the most powerful tool in your vasoplegia toolbox. As we peel back the layers of its unique mechanism, we will see how this molecule provides a metabolic brake on the pathologically dilated vasculature. Welcome to Pulse and Pressors, where critical care gets crystal clear. Methylene blue, or methylthioninium chloride, is a heterocyclic aromatic compound with a multifaceted clinical profile. We classify it primarily as a Guanylate Cyclase inhibitor. It also acts as a reversible, moderate-potency MAO inhibitor, a fact that carries significant safety implications. While it is the first-line antidote for drug-induced methemoglobinemia, its most studied targeted use today is in the management of post-cardiopulmonary bypass vasoplegic syndrome and other forms of refractory distributive shock. To understand methylene blue, you must understand the nitric oxide pathway. In states of systemic inflammation, like sepsis or post-bypass SIRS, there is a massive upregulation of nitric oxide. Methylene blue enters the cell and potently inhibits soluble guanylate cyclase, cutting off the production of cyclic GMP. It also acts by scavenging circulating nitric oxide and functionally inhibiting downstream INOS activity. By halting this signal transduction, we restore vascular tone and resensitize the adrenergic receptors to our primary vasopressors. The pharmacokinetics of methylene blue are characterized by rapid onset and a prolonged duration of action. After an IV bolus, clinical effects on MAP are often seen within minutes. With a distribution volume of 2 to 3 liters per kilogram, it moves extensively into the tissues. Elimination occurs via hepatic metabolism, with predominant renal excretion of metabolites. This is clinically significant because the drug's inhibitory effects on enzymes like monoamine oxidase can persist long after the initial hemodynamic boost, especially in the setting of renal impairment. The hemodynamic signature of methylene blue is defined by a sharp increase in systemic vascular resistance and mean arterial pressure. It is a pure afterload agent. While it is highly effective at closing the tank, practitioners must monitor the pulmonary vascular resistance, which may increase, particularly in patients with pre-existing pulmonary hypertension. Cardiac index is usually preserved, but it may decrease if the right ventricle fails, or if the afterload increase overshoots the heart's compensatory capacity. In the setting of vasoplegia, the standard bolus is 1 to 2 milligrams per kilogram, administered as a slow infusion over 20 to 60 minutes. Rapid administration can paradoxically cause transient hypotension or arrhythmias. While some centers utilize low-dose continuous infusions, typically 0.25 to 0.5 milligrams per kilogram per hour. Evidence for this is limited. Be cautious not to exceed a cumulative dose of 7 milligrams per kilogram to avoid inducing oxidative stress and secondary methemoglobinemia. Administering methylene blue requires high vigilance. Immediately following a bolus, the pulse oximeter will show a false, precipitous drop in saturation, often settling in the mid-80s. This is an optical interference, not true hypoxemia. You must rely on your arterial blood gas and CO oximetry. Additionally, patients will develop blue-green urine and a temporary blue tint to their skin. Finally, ensure your IV access is secure. Methylene blue is a potent tissue irritant, and extravasation can lead to localized necrosis. The most dangerous complication of methylene blue is its potential to trigger serotonin syndrome. Even a single dose can precipitate a crisis in susceptible patients. Because the drug inhibits MAOA, it prevents the breakdown of serotonin. In patients taking SSRIs or SNRIs, this can lead to a life-threatening serotonin storm. In a sedated patient, Watch for unexplained tachycardia, hyperthermia, or neuromuscular agitation like spontaneous clonus. If suspected, stop all serotonergic medications and consider cyproheptadine. In the cardiac population, methylene blue is a strategic tool but requires nuance. For patients with severe aortic stenosis, maintaining MAP is critical for coronary perfusion. However, it is relatively contraindicated or high risk in patients with obstructive HOCM, as increased afterload can worsen left ventricular outflow tract obstruction. Because methylene blue operates downstream of the adrenergic receptors, it remains fully effective in patients who are chronically beta-blocked, providing a reliable alternative when traditional pressors fail. Post-operative vasoplegia occurs in up to 25% of patients after bypass. We often consider rescue therapy when the mean arterial pressure remains below 65, despite escalating doses of norepinephrine. Early administration of methylene blue can stabilize the SVR and reduce the total catecholamine load. In the post-bypass environment, the volume of distribution is increased, and metabolic clearance may be altered, necessitating precise, weight-based dosing and careful monitoring of end-organ perfusion. The absolute hard stop for methylene blue is G6PD deficiency, as administration can induce a catastrophic hemolytic crisis. Always screen for this in your preoperative assessment. Severe hypersensitivity is also an absolute contraindication. While renal insufficiency is a relative contraindication, it is not a strict no. Instead, it requires dose spacing and extreme caution, as decreased clearance will significantly increase drug exposure and the risk of cumulative toxicity. Let's wrap up with 3 high-yield clinical pearls. First, remember that methylene blue turns the patient blue but saves the MAP. Trust your blood gas, not the pulse oximeter. Second, consider methylene blue as a bridge to recovery, allowing time for the underlying inflammatory response to settle. Finally, always communicate its use clearly to the team to explain the blue-green urine. Before we conclude, let's test your high-yield knowledge. If you have a post-CABG patient with a MAP of 52, but a preserved cardiac index of 2.8, remember that our primary target is soluble Guanylate Cyclase, and if that pulse ox drops to 86% while your ABG looks perfect, stay calm. It's just an optical artifact. Remember, Serotonin Syndrome is the silent threat for patients on SSRIs, and obstructive HOCM requires a very cautious approach to afterload. Keep your cumulative doses under 7 milligrams per kilogram to keep those red cells safe. No advanced clinical presentation is complete without the evidence that anchors it. Let us know what topics you would like to see discussed. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.